I'm Samant Prabhu at WashU, and I'm really thankful to Drs. Shin Ma and Yajing Wang for inviting me to talk about our work. I'm going to shift gears a little bit from this morning session and talk more about inflammation, which is the focus of our lab, and specifically how it relates to this disease, which is heart failure. These are two MRIs. The one on the left is a normal heart, and the one here is a failing heart showing a clear decline in cardiac function. But if we look beyond the cardiac structural and functional aspects as to what's going on in tissue, what we have seen is that the chronically failing heart, which is the focus of these studies, is an inflamed heart. And what we had proposed as a paradigm 4 years ago now in this model, the schematic, is that at the tissue level in failing myocardium, there is a expansion and activation of the immune system, both the non-cellular and cellular effectors of innate immunity and adaptive immunity. And in the myocardium, it manifests as an increase in the cell populations in the heart that relate to both innate immune cells, such as monocytes and macrophages and dendritic cells, as well as adaptive immune cells, such as T cells and B cells. And these cells are tissue injurious and lead to a state called para-inflammation, which is a chronic low-lying inflammatory response to ongoing stress in the myocardium. So if we look at specifically at the macrophage populations, there are multiple studies that show, at least in mouse hearts, and this has also been now extended to human hearts, that there are populations of macrophages in the myocardium that are derived from two ontological sources. One is a embryologically derived resident macrophage population, and the other is a monocyte-derived infiltrating macrophage population. And these, in a very kind of more simplistic view, can be categorized using two markers, CCR2 and MHC2. And what has been shown is that there are three populations: the CCR2 negative, MHC2 low population, which seems to be derived fairly exclusively from embryonically derived cells. There's an MHC2 high, CCR2 positive population that is derived from monocyte derived infiltrating macrophages, and a population of MHC2 high, CCR2 negative cells that can be derived from both populations. Now, in the presence of myocardial injuries, such as myocardial infarction, this leads to an influx and increase in monocyte-derived cells and an augmentation of the cell types that are derived from monocytes. And so there's been a lot of focus on CCR2 positive macrophages in the context of heart failure. But if you look at objectively at the numbers of macrophages in the failing heart, and this is an example from one of our studies, but this has also been validated using fate mapping studies. Even if you look at the chronic failing myocardium, while there's an increase in monocyte-derived infiltrating macrophages, CCR2 positive cells, the majority of cells are still these CCR2 negative populations, a large percentage of which are derived from resident macrophages. So we wanted to look and see if what these cells were doing. And if you look at some markers for resident macrophages, many of these are what we call M2-like. Now, that classification has fallen out of favor, but it still helps us to identify a population that can be activated by alternative, so-called alternatively activated macrophages that can be stimulated by Th2 cytokines. And so we focused on markers CD206 and CD163 as a perspective, as a framework to understand macrophage signaling in chronic heart failure. So if we look at resident CCR2 negative macrophages, they express classically alternatively activated genes. These marker genes are CD206, CD163, others such as YM1, ARG1, and FISI1. And it's been previously shown by Shirashi et al. In Japan that after acute MI, CD206 macrophages expand in the infarct zone. They're required for wound healing, but their role in chronic heart failure really is unknown. So we're interested in alternative activation, and this implies a activation that occurs via Th2 cytokines such as IL-4, IL-13 and IL-10. And this can occur through IL-4 receptor, primarily IL-4 receptor alpha, and IL-10 receptor, which has two subunits, IL-10 receptor alpha and beta. And we have previously shown that in the failing heart, the T cell milieu in the failing heart is primarily Th2 predominant. And this suggested to us that there was ongoing Th2 cytokine activation in failing myocardium that really had not been explored. So our hypothesis was that chronic Th2 alternative activation of CD206 macrophages in the failing heart induces this para-inflammatory state that we had proposed as a model for why inflammation drives progressive remodeling. Now this is all online in bioRxiv. It's currently under review, so all of this is actually online and you can look at it. But what we had done in this study is to induce myocardial infarction. And then our first step was to assess what happens to CD206 macrophages and what might be potential drivers of alternative activation in these macrophages. And what I've shown you here in flow cytometry is our gating strategy to look at F480 MERTK macrophages, two macrophage markers, and looked at CD206 expression at certain time points after MI, 48 hours, 1 week, 8 weeks, and so forth. And what you see here quantitated is that if you look early after MI, there's a large influx of macrophages. These are primarily CD206 negative, and by analogy, these would be the infiltrating CCR2 positive cells. But that over time, the CD206 negative population drops off, and in turn, there's an upsurge of CD206 positive macrophages that really, if you look at 8 weeks post-MI, the level of macrophage infiltration, incredibly, is almost the same as acutely after myocardial infarction. So this is a very inflamed heart and is chronically failing. If we look at the two cytokine receptors that I talked about, the primary, while there's a large double negative population that you can see here, but that are both IL-4 and IL-10 receptor negative, the primary population that express these receptors is IL-4 positive receptor alpha, CD206 positive macrophages that rise significantly in chronic heart failure. So what are these cells doing? Well, for one thing, if we look at markers of resident macrophages, they are primarily CCR2 negative, MHC2 high, so that middle subgroup that I showed you earlier. And if we look at LIVE1, which is proposed as a marker of resident cells, they're predominantly LIVE1 positive. And you can see that most of these cells then are what we would think are resident macrophages, but there's a contribution of CCR2 positive cells that occur in heart failure. So it's a mixed population, but still primarily have resident macrophage features. They're also associated with fibrotic regions. So this is a confocal image. The green here is staining with collagen hybridizing peptide. And what this does is it labels sites of collagen turnover. And what we see here is that the red here is CD206, and most of the CD206 macrophages are associated with CHP staining. And we talked earlier in the morning about the fibroinflammatory axis. This is really an immunofibrotic axis that we are seeing in the myocardium, where these macrophages are intimately associated with sites of collagen turnover. And in fact, they correlate very well with their amount of border zone fibrosis. We've also shown this with total fibrosis in the heart. And this occurs in the infarct zone, in the border zone, and even in the remote zone. You see that most of these cells are clustered around these fibrotic areas. So what else are they doing? They are proliferating. So these CD206 macrophages, this is using Ki67 as a cell proliferation marker. And what you see here is it's almost exclusively the CD206 positive cells that are proliferating in heart failure. And this suggests that that expansion that we are seeing in late heart failure is due, at least in part, to cell proliferation of these resident cells. We've confirmed this by the spatial distribution of cell proliferation using immunofluorescence. And what you can see here is that it's compared to sham animals. We look at the chronic heart failure in the infarct zone, the border zone, and remote zone. What we see is that most of the proliferating macrophages, surprisingly to us actually, was in the infarct zone and in the border zone. There's CD206 expansion everywhere, but the proliferation is occurring in the infarct border zones. And this suggests to us that this contributes to scar expansion. This can suggest to us that there is a hypoxic component that is contingent of hypoxia in the infarct scar. These cells become more proliferative and contribute to active remodeling. So this immunofibrotic axis is very interesting, and we did some studies using bone marrow-derived macrophages and polarized them with either IL-4 or IL-10. And what you see here is a flow cytometry showing that either of these Th2 cytokines will exclusively expand CD206 macrophages. And this is a collagen gel contraction assay. So what we've done here is to take conditioned media from IL-4 and IL-10 polarized macrophages and expose them to collagen gels that are imbued with cardiac mesenchymal stem cells that are capable of myofibroblast differentiation. And what you see in this representative slide is that only the MIL4 macrophages induce collagen gel contraction, indicating myofibroblast differentiation. So this spatial localization in the fibrotic regions is also associated in vivo with a myofibroblast differentiation potential for these macrophages. And you can see that this is the quantification of the area, and this is also quantification of alpha smooth muscle actin, the myofibroblast marker. And one of the things that we noticed doing gene expression in these macrophages is a very high level of FISI1, which has been shown to be a profibrotic marker in other disease states, including the lung and the kidney. And this is a really remarkable, more than 7,000-fold upregulation with IL-4 stimulation. So we'll come back to that in a bit. So what's the significance of all this? Well, if these cells are biologically active, then the transfer of these cells should induce remodeling changes. So here we took bone marrow-derived macrophages, polarized them either with IL-4 or IL-10, or with nothing, and then injected them via intramyocardial injection into naive mice. These are isotype mismatched mice. And what you can see by these representative echocardiograms is that only in the IL-4 polarized macrophage mice was there LV dilatation. You can see this by increase in chamber volumes, LV dysfunction with a reduction in ejection fraction, and LV hypertrophy shown here by increase in wall thickness and LV mass derived echocardiographically. So the adoptive transfer of MIL4 macrophages induces phenotype of LV remodeling in previously normal mice. And if you look at the histology, this not to our surprise, was also accompanied by an increase in fibrosis and an increase in transferred cells marked by CD45.2. These are donor cells. These donor cells, again, were associated with CHP positive locations in the myocardium, suggesting that there was active fibrotic responses being driven by the adoptively transferred macrophages. So if we step back, so that indicated to us that IL-4 signaling in CD206 macrophages is sufficient to induce the pathology of LV remodeling. What we wanted to next identify was whether this was necessary in the heart failure process to drive remodeling. So we step back and look, what are the other cell types? If we gate on IL-4 receptor alpha, is this exclusively macrophages, or are there different cell populations? And what I've shown you here is we're gating leukocytes first on IL-4 receptor alpha, and then looking at what populations of cells are these macrophages or are there other cell types. Using F480 MERTK, we see that most of these cells, more than 90 to 95%, are macrophages. And most of these cells, in turn, 95, 98% are CD206 positive. So we've also done studies with other cell types, neutrophils, T cells, monocytes. They express very low levels, comparatively, of IL-4 receptor. So in heart failure, most of the IL-4 receptor alpha signaling is occurring through macrophages, especially resident macrophages. So we then wanted to combine a therapeutic approach as well as a mechanistic approach for what is the role of IL-4 receptor alpha in these cardiac macrophages. And here we use gene silencing. So we gave antisense oligonucleotides, and they're abbreviated here by ASO. And these are antisense oligos against IL-4 receptor alpha. They're given systemically. We use mismatched oligos as controls. And we gave them to mice in the chronic stage of heart failure 4 weeks after either a sham operation or a coronary ligation. So from 4 weeks post-MI to 8 weeks post-MI, we performed IL-4 receptor alpha gene silencing. And I apologize, the pictures here got lost somehow. But what we saw here is that blocking IL-4 receptor alpha, silencing IL-4 receptor alpha, reduced heart weight, reduced lung weight, and reduced chamber size, and actually improved LV ejection fraction. So what this indicated is that blocking IL-4 receptor alpha signaling, presumably in macrophages, was sufficient to reverse LV remodeling. So this was an immune intervention that reversed cardiac phenotype. With further examination of the histology, we saw a reduction in border zone and remote zone fibrosis, fairly significant, with IL-4 receptor alpha silencing. And we saw a reduction in overall CD206 positive macrophages in the heart, a very significant reduction in IL-4 receptor alpha expression. Interestingly, a small increase in IL-10 receptor alpha expression, with total macrophages and IL-4 receptor alpha expressing resident macrophages decreased, and we saw a decrease in Ki67 positivity, indicating that we broke the cycle by reducing macrophage proliferation, and this is in line with the known effects of IL-4 as a cell proliferator, macrophage proliferator, induction of macrophage proliferation. Now, this was accompanied by no changes in the cytokine, the ligand, IL-4, no changes in IL-13, but a reduction in pro-inflammatory cytokines such as TNF, MCP1, MIP2 alpha, and IL-1 beta. So what this intervention did was to block signaling at the macrophage level. It led to a reduction in local inflammation by reducing macrophage number. It improved remodeling, and probably because of improved remodeling and function, reduced systemic inflammation. So really had a profound effect on the heart failure state. Now, I had mentioned that FISI1 was really high in the gene expression that we saw with MIL4 macrophages. And we looked at FISI1 expression here. This is in green here. We've co-localized that with CD206 macrophages, IL-4 receptor expression. There's some high MAG images here. But what I want to bring across is that nearly all of these CD206 positive, IL-4 positive, receptor positive macrophages express high levels of FISI1. And when we give the antisense oligos, we reduce the FISI1 expression of these cells. And if we go back to our in vitro study, FISI1 seems to be critical in terms of induction of myofibroblast differentiation in these mesenchymal stem cells. And here we showed this both with anti-FISI1, this is a secreted protein, so this is anti-FISI1 antibodies, and the use of FISI1 knockout bone marrow cells, showing that if we lose FISI1 function, we lose the myofibroblast driver that these macrophages induce on these cells. All right, so that was in mice. What about in humans? Well, at WashU and at my previous institution, UAB before that, we have a large biobank of failing human hearts. So we wanted to see, we collected some of these specimens and did flow cytometry. Do we see an expansion of CD206 macrophages in the human failing heart? And you can see here by the flow gates and the quantitation that there is a significant expansion of CD206 positive macrophages in human failing hearts. And they have the same relationship with fibrous tissue in human failing hearts that we see in mouse hearts, in that most of these cells are associated. Here we use CD163. We couldn't get the CD206 antibody to work in our immunofluorescence studies. But we use CD163 here, and we find that most of these are associated with zones of collagen turnover in human myocardium. And this corresponds with the increased fibrosis in these hearts. And much like in mice, the human analog of FISI1 is FISI3, which is also resistant. Resistant has prognostic importance in human heart failure. But the CD163 positive macrophages are primarily FISI3 positive. And most of the IL-1, IL-4 receptor alpha positive cells are FISI3 positive. And the correlation between CD163 cells and fibrosis is highly significant. So we feel that in human hearts, this macrophage population is also imparting significant biological effects. So what I've shown you here in these data is that these cardiac CT206 positive macrophages progressively expand after MI. And in heart failure, they comprise the predominant macrophage population in the failing heart. And they're very, very closely associated with sites of collagen turnover, suggesting that they are drivers of a local immunofibrotic axis in the heart. And that they are primarily have a resonant phenotype with CCR2 negative, a LIVE1 positive, sizable subpopulation expresses IL-4 receptor alpha, and there is attendant increased systemic levels of IL-4. I don't think I showed you that data. That if we look at macrophages that are polarized by IL-4, we see an increase in FISI-1 and FISI-1 dependent myofibroblast differentiation. That intramyocardial adoptive transfer of IL-4 polarized macrophages is sufficient to induce remodeling. The flip side is that IL-4 receptor alpha silencing reverses remodeling and depletes CD206 positive macrophages, and that humans also express an expansion of alternatively activated macrophages marked by CD206 and CD163, again with association with FISI-3, the human analog of FISI-1, and association with fibrosis. So what I'd like to propose is that there's a paradigm where we have alternative activated macrophages expanding in heart failure, that they induce a Th2-M2-like parainflammation and an immunofibrotic response that's dependent on FISI-1. And that so if we could target either IL-4 signaling or FISI-1 in macrophages, we might be able to reverse disease in an immunomodulatory approach to reverse remodeling and improve heart failure. With that, thank you for the invitation. I'd like to stop, but I also want to acknowledge all of the people that worked on this, especially Xiangxing Wang, who drove all these studies. She was a former postdoc in the lab. She now has a faculty position in Wuhan University. And she met me earlier, was very hospitable. She had to leave, so she couldn't see her data being presented. But thank everybody else in my lab, as well as prior lab members. Thank you very much.